So let's start with the first one. And this is something, actually it's second MBBS microbiology, but it comes in entrances, even at a surgical level. So who among the following identified that puerperal sepsis is reduced by hand washing? So back in the days when there used to be deliveries, there was a very high maternal mortality, not just because of APH, PPH, but because of puerperal sepsis. Still, there was a doctor who identified that the deliveries which were happening by staff nurses had a much lower mortality or puerperal sepsis compared to those which were done by untrained professionals or even doctors for that matter. And the simple reason they found was there were these doctors who were doing delivery after seeing patients and after doing autopsies. So the same doctor after autopsy comes for a delivery, and that mother later on gets puerperal sepsis. This was identified by Semmelweis. So he started telling the doctors that after doing autopsy, just wash your hands. And when they started doing hand washing, the risk of puerperal sepsis, the incidence reduced from 10% to 2%. Initially, this was resisted a lot because, doctors have their egos and they were like, no, it's not because of us. They didn't know there were bacteria, microorganisms. They were like, how is it that we are carrying anything from a dead body to a mother whose delivery we are doing? But this was proved after Semmelweis' death. So he was the original founder of this principle, but it was introduced into practice after his death, which was so strange. So he was the one who found simple act of hand washing reduce the incidence of sepsis. Then of course, Louis Pasteur, he's done so many things, pasteurization of milk and all. He gave the germ theory that microorganisms are responsible for infections. Right, and then you have Joseph Lister, father of antiseptics, who used phenol or carbolic acid as an antiseptic. And Zauber Kugel, this is the name you should know. This can be a future question. He said that microbes can be killed by certain magic bullets, which later became antibiotics. He did not find antibiotics, but he said it's not the host which is killing. There are some antibacterial components which will kill the bacteria or which will kill the microbe. So these are some of the findings of some of the scientists in the field of microbiology. This is something every surgeon should know, that following a breach in tissue integrity, what is the critical time window before bacterial colonization? Simple example, when I'm doing a surgery, when I'm about to cut the skin, right, I am supposed to give preoperative antibiotics, right? We give pre-op antibiotics, which we will normally give at the time of induction of anesthesia, approximately 30 to 60 minutes prior to incision. Now, why do we give it approximately 30 to 60 minutes prior to incision? So that when the time comes for the surgeon to take the cut, the concentration of the antimicrobial is high enough in the blood. You have high levels of your microorganisms to be killed, that is your antibiotics in blood. So there are high levels of antibiotics by the time the incision time comes. But the problem is we give one dose. Let's say surgery goes on for a long time, 10 hours, 12 hours, you're doing a Whipple's procedure. Should you repeat the antimicrobial dose? Answer is yes, because this critical time window is 4 hours. So the rule that we follow in practice is every 4 hours. So if the surgery is getting prolonged, every 4 hours, you should give a antibacterial dose. So you should repeat antibiotics intraoperatively if you are doing a surgery which is lasting for more than 4 hours. Normally, if it's a 2-3 hour surgery, single dose pre-op is fine. But if it's getting prolonged, every 4-hourly interval intraoperatively, you are going to give an antibiotic because this is the critical period. Okay, the window within which the bacteria will get established in the wound. Okay, simple enough question. All are associated with the risk of development of surgical site infections, except even when I have taught you wounds. Now we know what are the factors which affect wound healing. The same kind of factors will kind of affect the risk of surgical site infections. So what will affect the risk? People who have obesity, of course, because obesity is associated with atherosclerosis, poor vascularity of the surgical site. So it will increase the risk of wounds getting infected. Uremia, yes. So this is something from Bailey. Any metabolic disease of a significant magnitude, like uncontrolled diabetes, we all know, but here I put the option of uremia. Okay, because everybody knows diabetes. Jaundice will all affect wound healing because your metabolism will be altered, your immune system will be altered. Obviously, immunosuppression will affect wound healing. Goes without saying, so steroids, chemotherapy, immunosuppressing diseases, right? Surgeries where there was a contaminated surgeries, like a GI surgery where there was a bowel which was perforated, or during cholecystectomy, if the gallbladder burst, surgery becomes contaminated, increase the risk of SSI. Poor tissue perfusion. So certain sites where the perfusion is poor are at a more risk. Presence of foreign body in the wound, especially for us surgeons, mesh. Whenever we do hernia repair, if you are putting a mesh, or for orthopedics, if you are putting an implant, TKR, THR implant, these are very critical areas where risk of wound infection is high, because if the bacteria gets contaminates the implant, it will remain there forever. And of course, poor surgical techniques of certain kinds, like now this is a little broad specific, but what can they ask you in the question is what you should know. So devitalized tissue or necrotic tissue, obviously dead space. Now very important here, dead space. So dead space increases the risk, which is why if the wound has a lot of depth, we tend to obliterate it, and closure of dead space is a good thing. So the answer here is option D. Foreign body will increase the risk like implants, but dead space, if you don't close it, that will be the risk factor. So closure of dead space obviously will reduce the risk. Surgical site hematomas. So these are some of the things which are associated with wound infection. Another concept they love asking in the exam that you should know about, which of the following statements is incorrect regarding prevention and management of CLABSI. CLABSI is central line associated bloodstream infection, basically catheter-induced sepsis. One of the commonest complications of keeping necklines or central lines for long duration is if the line gets infected because it is exposed to the environment. So when every time you're giving some IV fluid, blood product, or even TPN, it gets exposed, right? That's why a lot of hygiene has to be established and practiced. Now, what is incorrect? Povidone iodine is preferred over chlorhexidine for skin preparation prior to insertion of a central venous catheter. This is the incorrect answer. Alcohol-based solutions have lower risk, and chlorhexidine also has a lower risk. So the best answer here, it should be alcohol-based solutions or chlorhexidine, not povidone iodine. So skin preparation should be with chlorhexidine, preferably compared to povidone iodine. This is a direct line from Bailey. Okay, so this is from the Bailey chapter of surgical infections. Hickman lines are associated with a lower risk compared to non-tunneled percutaneous catheters. This is true. Hickman lines are special type of necklines where part of the tube is tunneled subcutaneously before entering into the IJV. Okay, so that's a tunneled subcutaneous line. That is Hickman catheter. Obviously, there is lesser exposure of the line to the environment. So obviously, it will have a lesser risk. MRSC, methicillin-resistant staph epididymitis, is a common cause of catheter-related infections. It's true. So MRSC, MRSA, streptococci, skin commensals are the ones which will commonly enter. And management of CLABSI is not very easy. But first thing you have to do is you have to remove the catheter. You must have done this so many times. If you are suspecting post fever after neckline, and obviously have to give IV antibiotics for a minimum of 2 weeks, because these infections are fairly resistant. And there's a direct septicemia, right? Once the line is infected, it will go straight into the bloodstream. So best answer here is option A. This is a little trick question. Okay, this is a little trick question. Patient underwent knee replacement surgery 15 days ago. For how long should he be monitored for potential surgical site infection? Now, clinical practice and meaning of SSI are not the same. In practice, you do TKR, you remove the skin sutures, you tell the person, go home, fine, cool. But in practice, till when will I call it an SSI or a surgical site infection? So the meaning of a surgical site infection is infection of the surgical site within. 4 weeks or 28 days. Or some people will say 30 days. It should be within 4 weeks. Or in case of implant, if you have put an implant, it should be within 1 year. Okay, it should be within 1 year if you have put an implant. So I will say surgical site infection in context of an implant like a mesh or a TKR prosthesis is going to be 1 year. So as strange as it may sound to you, for how long should he be monitored? Basically, you will label the person as having SSI if he gets a wound infection up to 1 year after an implant. Right? So answer here is option D. Okay, these are the kind of questions which can really trouble us, and they are not the most difficult questions, so don't get them wrong. You should have a little bit of idea about them for sure. Okay, little idea is always required for these kind of topics. Patient undergoes laparotomy for peritonitis. On post-op day 3, he develops pus discharge around the suture line and fever. What is the Southampton score? So Southampton score and the other one is asepsis score. They are post-operative wound scores or wound grading. Okay, they are scores or they are types of wound grading. Basically, they will tell you the severity of wound infection if it gets infected. Obviously, grade 0 means it has healed normally. Nothing has happened. Grade 1 is okay, very mild, like just some bruising, some erythema, nothing. Where should you be careful? Erythema plus other signs of inflammation is going to be grade 2. Okay, you don't need to know the subtypes, at least know the basic types. That erythema plus some signs of inflammation is going to be grade 2. And this is where it gets tricky. Grade 3 and grade 4, there will be some discharge. In grade 3, there will be serosanguinous discharge. And grade 4, which is a major complication, there will be purulent discharge. Grade 5, tissue has broken down. Tissue is gaped. Normally in practice, we diagnose wound infections either in grade 3 or grade 4. They are where we will diagnose them clinically. Grade 1 and grade 2, we don't even diagnose. We just see a little bit of redness, we attribute it to something else. Serous discharge is grade 3. Purulent discharge is grade 4. That is what you should know. Here there is purulent discharge, answer is going to be grade 4. That's how you should think, right? This is a trick question. This has been asked in a lot of entrances, not just at a PG or a UG level, but entrances across, because you know, this asepsis wound score, the components are given by the name asepsis. So you have A for additional treatment, S for serial discharge, E for erythema, P for purulent or pus, S for separation, I for isolation, S for prolonged stay. And you score the person. Okay, you give the person a score. Higher the score, more severe is the wound infection. And they will give you options arising out of these letters asepsis only. But where will you make a mistake? Is serious discharge a marker of wound? Of course it is. Pus, obviously it is. Erythema is, right? It is also in Southampton score. I for induration is wrong. I stands for isolation of bacteria. Okay, so normally they will either give you a fourth S. So you have serious discharge, separation, stays prolonged, and there will be a fourth S, which will be the wrong one, or I will be replaced by induration, some finding instead of isolation of bacteria from wound. So you think like that, then you will get the answer correctly. You should know if they want to change the question or if they want to change the options, which one will they change? It will either be one of the S's or it will be I for induration, which is what I did in this question. Right. Easy question. 55-year-old male presents with erythema and swelling in the lower limb. I am sure you must have seen this photo in so many times in your clinical practice. What is correct or what is incorrect? So this is nothing but cellulitis. Lower limb cellulitis, which is seen for various reasons. Residents also get it all the time if they are standing prolonged and there are some minor scratches and bruises. Basically, what happens? Either there is some predisposition like diabetes and the skin is of poor quality because of poor hygiene or because of dryness. The skin commensals enter the subcute and they cause an inflammation. It's inflammation of the subcute. Cellulite means fat. itis, inflammation of subcutaneous fat. Why? What is the reason for it? Streptococci, staphylococci, staph epidermidis. They are the ones which will cause cellulitis. Pus formation is a typical feature is wrong. There is only inflammation. There should be no pus. If you get pus formation, it's a dangerous thing. Because if you start getting pus formation, that means the bacteria is very virulent and it will not remain in the subcute. It will start entering into the facial planes. So you may get abscess. So if pus is present, it may form an abscess. Or even worse, if you are an immunocompromised patient, it may lead to necrotizing fasciitis, which is even worse. But that will only happen if you are immunosuppressed. It won't happen in you and me normally. If untreated, may progress to sepsis. Yes, it is possible, especially if you are immunosuppressed. It mimics lymphangitis. Yes, it does. Because even if there is lymphangitis, you will see these local inflammatory findings, very similar. So you see local inflammation. But the difference is you will see red streaks of inflamed lymphatics. That will tell you, and of course, there will be significant lymphadenopathy. Those red streaks will tell you there is lymphangitis. Okay, lymphangitis follows a similar pathophysiology. Easy concept, what is not a component of SIRS? Systemic Inflammatory Response Syndrome. SIRS is nothing but your body's response to severe injury or severe illness. It's body's response to severe illness or injury. Like you have a road traffic accident, or you undergo a major surgery, or you have a bad infection, bronchopneumonia, or endocarditis, some bad infection. So what happens to your body? Your body tries to mount an immune response, which gives you some clinical findings. Those clinical findings you can simply remember by the mnemonic, what you see in clinical practice, TPR, temperature, pulse, respiration. And then there is BP, but the fourth point is not BP. The fourth point here is WBC, because WBC will tell you, inflammatory response. T will be more than 38 or less than 36. So option A is correct. P or pulse rate should be more than 90, which is not there in the option. Respiratory rate should be more than 20. That is correct. Or because of high respiratory rate, your PaCO2 should be less than 32 is also correct. And the fourth is WBC count. It should be more than 12K. There should be leukocytosis or even leukopenia. Understand? Leukopenia is also a marker of severe illness. In fact, it is worse. It is seen in the later stages of SIRS and sepsis. So these three markers are correct. The fourth marker is a pulse rate, which is not in the option. Serum lactate is not a criteria for SIRS. Okay, so though serum lactate is useful, it helps in diagnosing hypoxemia. Or better yet, it is a marker of shock. It is a marker of tissue hypoxia or shock. It's not a marker of SIRS. Okay, for SIRS, there are these four criteria. And remember, any 2 out of 4, if they are present, you can tell that the person is in the state of SIRS, even if 2 out of 4 are present in the patient.